Good morning, everyone. I'm going to be presenting the outcomes of MIGS KDB versus Npds phaco in eyes with advanced glaucoma. As we all know, the goal of any glaucoma surgery in general is to preserve the existing vision and to halt the disease progression. However, in advanced glaucoma, there is always a risk of macular snuff-out or wipeout phenomenon, which has been reported to be as high as 13.6%. Previously, literature reports have clearly shown that non-penetrating surgeries are a safer alternative to trabeculectomy in such high-risk individuals. Although minimally invasive glaucoma surgeries have a high safety profile, its role in advanced glaucoma is still not known. Non-penetrating surgeries, though preferred in advanced disease, it is still a bleb-forming procedure, and the outcomes are still unpredictable. So the aim of our study was to compare the safety and efficacy of combined KDB phaco versus Npds phaco in eyes with advanced glaucoma. So this was a retrospective comparative study, and we included 114 patients with Group A, that is KDB phaco, having 49 patients, and Group B, that is Npds phaco, having 65 patients. So we included patients more than 18 years of age with open angles and those who had an advanced glaucoma with a significant cataract. We excluded patients who underwent a standalone procedure, those who had poor visual acuity, who were not able to perform a reliable visual field, and when patients had any intraoperative complication. So a detailed preoperative evaluation was done in all of these patients. Postoperatively, we followed a routine protocol of antibiotic steroids, which were tapered over 6 weeks. Cycloplegics were used. And whenever a bleb rescue procedure was needed, like a laser goniopuncture or bleb needling, that was considered as part of postoperative protocol. Postoperatively, patients were reviewed on day 1, 2 weeks, 1, 3, 6, and 12 months. At every visit, vision, intraocular pressure, anti-glaucoma medications were all recorded. Visual fields, however, were done only at 6 months and at 1 year, and any intraoperative or postoperative complications and interventions were all noted. So looking at the result, this was a baseline characteristics between Group A and Group B. Interestingly, the Npds group had more requirement for anti-glaucoma medications preoperatively, and they also had a slightly worse visual field mean deviation compared to the KDB group. So looking at the primary outcomes, which was intraocular pressure reduction and the reduction in the number of anti-glaucoma medication, there was a significant reduction in intraocular pressure in both the groups. However, the KDB group had significantly greater number of patients, that is 50% of patients, not requiring any anti-glaucoma medications and had a better IOP control without medications compared to only 5% in the Npds group. Looking at the secondary outcomes, because we were talking about patients with advanced glaucoma, so what is more concerned is stable visual acuity and visual fields. So both the groups had a significantly stable visual outcomes and visual fields. However, the baseline itself was really worse in the Npds group, so that continued even in the postoperative visits. The success criteria based on criteria 1, which is intraocular pressure reduction of more than 30%, we had a complete success, which was seen in the KDB group with 50% not requiring AGM in all follow-up visits. However, only 5% of our patients in the Npds group had not required any AGM. So based on the criteria 2, there was no big difference between the two groups, which was essentially based on visual field stability and visual acuity outcomes. This was a Kaplan-Meier survival analysis based on the criteria 2, which was similar. The interventions and complications were also mostly similar. However, there were 12 patients, that is 24% of our patients in the KDB group, which reported to have hyphema but did not require any surgical intervention for AC wash or anything like that. However, there were 3 patients in both the groups who required intervention in terms of diode or DRAB or RD to decrease the intraocular pressure. The results clearly showed that both the groups had similar intraocular pressure reduction in advanced glaucoma, maintaining a stable postoperative visual acuity in central fields. However, the KDB group had a greater reduction in the number of AGM, with 50% not requiring any medications compared to only 5% in the Npds group. There was no major vision-threatening complications in both the groups, and similar need for any pressure-reducing surgery in both the groups. Compared previously to the previous studies, it was clearly shown that MIGS or phaco was safe in severe glaucoma. However, the resurgery rates was only 9.9% in MIGS phaco compared to 33% in patients who underwent a TRAB earlier. And only one study had compared this Npds phaco versus MIGS phaco in the literature, which was only in moderate glaucoma, that was using eye stent. And in that study, they have shown that Npds had better surgical outcome with more interventions. Our study also, we found that there were more number of interventions required in Npds phaco in terms of goniopuncture and bleb needling. So the clinical relevance of this study is, it is a bleb-dependent procedure, definitely causes more IOP control. However, our results clearly showed that There was similar IOP reduction in both the groups, but KDB phaco had better complete success with 50% not requiring anti-glaucoma medications compared to only 5% in the NPDS group. The visual outcomes and the postoperative visual fields were stable in both the groups, and there was also no difference in terms of complications and loss of central vision. The strength of our study, this is the first study which was comparing these two, and it is done in advanced glaucoma. It is a retrospective study. There was only 10% who lost to follow-up. Both the groups were equally efficacious and safe in patients with advanced glaucoma. Thank you.
Thank you, Dr. Sharmila.